we have Dr. Amanda Rosenkrantz. She is the medical director for the HIV/HCV program at the Baltimore City Health Department. She has been the medical director for the HIV and HCV at the Baltimore City Health Department clinics for 6 years, since 2016. She is credentialed as an HIV specialist by the American Academy of HIV Medicine. So please join me in welcoming Dr. Amanda Rosenkrantz.
Hey everyone. I know I haven't been here throughout the day, so just a quick show of hands. Who here works in a local health department? Most people. Okay. Who is a clinician or a nurse? Medical folks. Okay. Is anybody treating Hep C right now, or hope to in the near future? I know you guys are. Okay. Cool.
And keep in mind, we have 100 people online.
Oh, who I can't see. Great. A lot of them are clinicians.
Some people are raising their
Okay.
hands. Yes. Some are.
So today I wanted to kind of give an overview of Hep C. I'm not going to go into a lot of the details about treatment, but I want to try to keep it relevant for what you all might need. I'm going to start just giving an overview of Hep A and Hep B screening and vaccination. Talk about Hepatitis C transmission and disease course, some of the epi of Hep C across the country and in Maryland, Hep C screening and initial evaluation, how we stage liver disease and the process through treatment and cure. So hepatitis A. Now, hepatitis A, B, and C, as you all probably know, are 3 different viruses, and we kind of lump them all together because they all affect the liver, but they're all quite different viruses. Hepatitis A is transmitted through fecal-oral transmission. All of these could end up having similar symptoms because of their effect on the liver. So fatigue, nausea, abdominal pain, low-grade fever, etc., yellowing of the skin and eyes. It does not become a chronic infection. So hepatitis A is an acute infection that you get. It can make you acutely ill, but it resolves over weeks or a month period. Most importantly, we have a vaccine to prevent hepatitis A, which kids get routinely as part of the immunization schedule now, but for those of us who are older, we didn't get it as children. And so a lot of adults have not been immunized against hepatitis A, but it's 2 doses given 6 months apart. What's important is that there's been an increase in hepatitis A cases across the country over the past couple of years. And particularly on the East Coast, you can see kind of a distribution there. And I think here I have some numbers. So from 2016, there have been outbreaks in at least 37 cases, 37 states, 43,000 cases. So despite this being a vaccine preventable disease, there are these outbreaks, particularly among people who are high risk. So people who inject drugs, people who have unstable housing or experiencing homelessness, men who have sex with men, recently incarcerated. These are the sort of populations that we're seeing increased Hep A cases in. And so just want to put a plug out there for if you work in a situation where you have access to hepatitis A vaccine, that you're really offering that, particularly to these groups of folks to make sure that they're protected. So hepatitis B is spread through blood, semen, body fluids, and from mother to baby. And less than half of people have symptoms when they get hepatitis B. And unlike hepatitis A, this can become a chronic infection. It does not become a chronic infection in everybody. And it's a very prevalent worldwide and causes significant morbidity and mortality worldwide. And there's approximately 850,000 to 2.2 million people in the US who are chronic Hep B carriers. So there is a vaccine for hepatitis B. There is not a cure, but there are effective antiviral treatments for people who require treatment. But like HIV, they're suppressive treatments and they're not cures. This is sort of for your reference, but for those of you who are used to looking at Hep B lab tests, Hep B is kind of complicated to assess whether somebody is immune, whether they have been exposed to hepatitis B in the past, whether they have a chronic infection. So this table you'll have for your reference. A couple of things that I wanted to point out. When you're checking serology for hepatitis B, the surface antibody is the one that really shows you that someone's been immunized and they are immune to hepatitis B from immunization, you can also get that positive surface antibody from a natural infection. And so when you check that, you know that like somebody has at least some immunity to Hep B. Hep B vaccine actually is oftentimes people, even if they're vaccinated as a child, that immunity can fade over time, and sometimes people need a second course. And any of you who worked in healthcare, they check your immunity when you're starting at your job, and they revaccinate you if you need it. The other antibody I wanted to point out is the anti-HBC, which is the core antibody. So that antibody can only be positive if you've been exposed to hepatitis B in the past, since you've had the infection in your body. So what I see a lot when I'm evaluating people for hepatitis C, which we're going to get to, I always check the surface antibody, the core antibody, and the surface antigen. I get a lot of people whose those three labs come back with just a core antibody that's been positive, and you'll see here what that means is that they've had an infection in the past, but it could also mean that they have a latent or chronic low-level infection kind of hanging out that isn't coming up with a positive antigen test. This is just something that we keep in mind when we're treating folks, because I didn't realize how prevalent this particular scenario was until I started testing people who I'm going to treat for Hep C, and this positive core antibody kind of comes up a lot. So a lot of people have been exposed and aren't immune from vaccine, but in those cases, whenever they have a negative surface antibody, you can go ahead and vaccinate them again and help them build up that surface antibody immunity. So again, those vaccines, Hep B, the standard is a 3-dose series. It also comes in a combination Hep A, Hep B, which I think you can give as a 2-dose series. And for most people, kind of younger folks, I say younger than me, started getting this as routine vaccination at birth. So all kids and younger adults have been vaccinated, but there are some older adults who have not been. But again, these are categories of folks you'd want to make sure that they're immunized against Hep B if they are not immune. So moving on to Hep C. So here is sort of an overall map. This is HepView, is a website where they track hepatitis C kind of prevalence across the country, and they also track some other interesting things like barriers to getting treatment in various states. And so there's an estimated 2.4 to 2.7 million people living with chronic Hep C in the US. Those of you that are familiar with sort of looking at an HIV care continuum, this is kind of an estimate of where we are with Hep C. I think the data is not nearly as strong for Hep C in terms of just having the actual data to know where people are in this continuum. But basically what you can see here is that really only about 1/3 of people with chronic Hep C have actually been treated and cured for their infection. So just last year, Maryland, for the first time ever, released a viral hepatitis epidemiologic profile. So this was really exciting because we really hadn't had good data for Maryland specifically previously. And just for your reference in here is kind of a snapshot. So there's about 72,000 people in Maryland living with chronic Hep C. And then you can see up on some special populations up there, about 12% of people with HIV are co-infected with hepatitis C. Right now for you here. Anyway, this is in there for your reference, and they have a full PDF along document if you're interested in that. I thought this slide was interesting because it kind of shows different population, the percent or the prevalence amongst different populations within Maryland. So you can see like the really high prevalence populations are people who've been incarcerated, people experiencing unsheltered homelessness. Those have prevalences of 14 to 16% compared to some of the other populations. Predominantly amongst African American population have a much higher prevalence. And there is quite a distribution. There's the birth cohort is shown there, and several years ago, the highest proportion of people with chronic hepatitis C were kind of in the baby boomer population. But we've just been having more and more infections in kind of younger people as it continues to spread, particularly with the opioid epidemic and drug use. More younger people are getting Hep C now. And this is, if you're interested, you can see that the highest number of cases is in Baltimore City, but then you can see down to Harford County, there's 763 folks compared to the 8,000 that are in Baltimore City with chronic Hep C. So hepatitis C transmission and disease course. So Hep C, there's no vaccine, unfortunately, to prevent Hep C. And unlike the other hepatitis viruses, it's really only spread through blood contact. So it's not in semen, it's not in vaginal fluid, it is in blood. So the most common way that I experience that folks are transmitting it is through sharing drug injecting or snorting equipment. It can be spread through sex, particularly when there's in types of sex where there's more trauma to the tissue or there's blood involved. So anal sex, men who have sex with men are at higher risk for sexual transmission, and condoms do help prevent that. Sharing personal items, we always list these things. I'm not really sure how often this is really involved in transmission, but if someone's sharing things that can have specks of blood on them, even if you don't see them, so razor blades, toothbrushes, nail clippers, things like that. Unregulated tattoos, this is pretty common, and particularly people who are getting tattoos while they're incarcerated, they're going to have kind of unsterile needles in that situation. Needle sticks in healthcare. And then mother to child transmission is about 5 to 10% perinatal transmission to the child. Blood transfusions were really or transplants before 1992. That's when we learned about hepatitis C virus and started screening the blood supply. So sometimes folks, especially in the baby boomer population, where if they got blood transfusions or things in the 80s and 90s, early 90s, they may not have been screening the blood supply at that time. So that is a way that folks have gotten it. So when somebody gets the infection, only about 20 to 30% of people have symptoms when they have a new infection. So that means the vast majority of people don't have any symptoms at all when they get infected. And the time course and natural history of Hep C is that once you get the infection in your body, about 20% of people, their body just gets rid of the infection without any treatment. We don't really know why or understand that entirely, but they're the lucky 20%. So we call that spontaneous clearance. But that means 80% of people go on to develop a chronic infection. And those 80% of people over years and decades, the virus kind of hangs out in the liver and causes chronic inflammation in the liver and eventually some scarring of the liver. So 20% of people who have a chronic infection are going to go on to develop cirrhosis if untreated. The time course of that for any given individual is hard to predict, and the amount of damage that to the liver for any individual is hard to predict. But certainly things like alcohol use, co-infection with HIV or Hep B are going to accelerate that scarring process in the liver. People who are women or people who are younger when they got the infection are less likely to have more significant damage. But again, for any individual, it's hard to predict. And then of those people who develop cirrhosis, there's a risk of liver cancer, so hepatocellular carcinoma, about 1 to 4% per year. So this is really why we care so much about hepatitis C, is because if you progress to cirrhosis, cirrhosis alone can eventually kill you if you go into decompensated cirrhosis and your liver stops working. You can die from cirrhosis, but then also once you get to that level of liver damage, there's also a chance of liver cancer. And I really like this slide, even though it's a little bit old at this point, because when I saw this, it was the first time that I really realized the morbidity and mortality impact of hepatitis C. What this shows is that kind of over this decade of time, hepatitis C was causing more mortality than 60 other infectious diseases combined, including HIV, TB, and MRSA. And so, you know, it really is, you saw the numbers of how many people in our country and in our state have chronic Hep C, and knowing that we can prevent that morbidity and mortality trajectory with a cure is really important. So hepatitis C screening. So here's our first poll. Who should be tested for Hep C? An HIV positive sexually active man who has sex with men who was tested last for Hep C 2 years ago. B, a 21-year-old woman who has never been tested for Hep C but has no risk factors or exposures. Or C, a pregnant woman with no risk behaviors or exposures who was tested for Hep C during her last pregnancy. Or D, all of the above. Do I need to do anything? No.
Was there a poll before that?
I thought that there was, but I didn't see one, and I might have accidentally skipped it.
Yeah, we passed it. So go to poll 2. Because the first one was asking, just to give you an idea. He's got the second poll. up
I don't
there.
know how I skipped the first one, but I did, I guess.
Any thoughts? A, B, C, or D here? Yes, I agree.
Do you stop it at some point, or what?
I'd like to hit 50%.
Okay, got it. I just can't really see what's happening.
There we go. So you've got, yeah, at least 60 to 70% all the above.
Okay, that's great. Well done. So just to quickly go over that. So oops, let me go back. I'm going to show you on the next slide the snapshot of the screening recommendations. But first, the screening recommendations now, as of like 2 years ago, say all adults should be screened at least one time in their life, regardless of known risk factors. People who are high risk or have repeated, risk of infection should be tested more often. So in this first one, HIV positive man who was having sex with men, tested 2 years ago. He falls into a category of someone who should probably be tested once a year. So he should be tested again. 21-year-old woman with no risk factors, she should be tested based on the new guidelines, even though we don't know if she has any risk factors. And a pregnant woman should be tested during each pregnancy. So that's why that's the answer there is all of the above. So this is a screenshot. I'm going to have several of these directly from the hcvguidelines.org. These guidelines are excellent and updated frequently. All the evidence is kind of supported there on the website, and so I really recommend you using this. I reference it frequently to make sure that I'm up to date on everything. But regardless, this is the sort of screening recommendations, and it is kind of some of the things that we just talked about. The first bullet point being routine opt-out Hep C testing for everybody, for all adults, regardless of risk factors. So really the same as we're talking about for HIV. There's like the recommendations for the one-time screening, and then the prenatal screening like we talked about during each pregnancy, and then the periodic testing for people who have ongoing risk or increased risk. So some of the risk categories and exposures that we talk about here that you might consider screening people annually or with some regular frequency are, injection drug use, intranasal drug use. I still consider that a risk, even if people tell me that they've never injected. I think that there is some sharing of equipment there that can transmit Hep C. Use of glass crack pipes, men who have sex with men, or people who are having riskier sexual behaviors in the setting of drug use. And then risk exposures, so people, these are some of these are like healthcare related, to people in dialysis, people in long-term care facilities, people who've known they've had an exposure, and then children born to Hep C infected women. I'm not going to really talk about that today, but like I mentioned, there is a 5 to 10% perinatal transmission rate. So children born to those women should be tested, and there's like a screening algorithm for that where they should be followed by the pediatrician. And then people who got those blood transfusions or transplants kind of early on. But again, that's not something that we're going to kind of repeat testing for. People who are incarcerated, again, a risk sort of category, especially if they got any tattoos during that setting or got it. There's just lots of ways to get exposed to other people's blood while you're incarcerated. And then the other sort of conditions here, when you're evaluating people for starting PrEP, new HIV infection, or evaluation of chronic liver disease. So the screening algorithm is really kind of a two-step process. So the first step is to check a hepatitis C antibody. So this is, the rapid tests that we have are antibody tests. You can also do a serologic antibody test. Whether somebody has been cured or whether they spontaneously cleared, that antibody test is always going to be positive. So if that's positive, they've had the infection at some point, and the next step is to check for the viral load or the RNA. So if the antibody is reactive, then you move on to checking the RNA. And some labs now, you can order the reflex testing, so you can order a reflex antibody to an RNA if it's positive. If the RNA is negative after the antibody was positive, it means it means they don't have a current infection, but it means either they were previously cured of their hepatitis C or they had that spontaneous clearance. They were in that 20% of people who cleared the infection without treatment. If the RNA is positive, that means they have a current Hep C infection, and they should be evaluated for treatment. So Hep C treatment. Next poll, who should be evaluated for Hep C treatment? A 45-year-old man who actively injects drugs and is not in a drug treatment program, a 30-year-old woman with a Metaveer score of F0, meaning with no liver fibrosis, a 65-year-old man with cirrhosis, or all of the above. Okay, 4%. And most are saying D, all of the above, which is excellent. So just to review why that's the answer. So the first person who is actively using drugs and not in drug treatment, drug use and alcohol use are not a reason to deny hepatitis C curative treatment. This is something that is very common, that used to be part of criteria for getting approved for medication, that a lot of providers still kind of require people to be abstinent from drugs or alcohol before treatment, and that is not medically supported by the literature, and it is recommended that everybody get evaluated for treatment. B, we're going to go over the guidelines here, but everybody, regardless of stage of liver fibrosis, should be evaluated for treatment. That is the current recommendation. In the state of Maryland, there used to be restrictions about medication coverage, which I'll talk about a little bit, but those have been removed. And then certainly an older person with cirrhosis, even though they've already progressed to that level of liver damage, absolutely should still be treated. So the goal, so who to treat? The goal of treatment is to reduce morbidity and mortality from those reasons that we talked about, by removing the virus from the person's body, and then secondarily, really to prevent transmission to other people. And so treatment is recommended for everybody with acute or chronic hepatitis C, regardless of stage of liver fibrosis. The only reason, and this is a little bit more of a complicated case, the only reason to not treat somebody based on sort of their condition is if they have, for example, end stage, cancer or something that's going to really limit their life to less than a year. And that would be the case where it's not necessarily the most effective sort of use of resources to treat them, because we're not going to prevent significant morbidity or mortality in them. So those are cases that would be evaluated probably more by a specialist, but really everybody else should be evaluated for treatment. I will say, even though the clinical guidelines say to treat acute hepatitis C, currently in the state of Maryland, the Medicaid program, so I see most of the patients that I treat are on Medicaid. Medicaid does not approve treatment for acute hepatitis C. They only approve treatment for chronic hepatitis C. And we're sort of advocating to change that, but that's kind of where we are right now. And what that means practically is that they consider an acute infection an infection of less than 6 months. So those 20% of lucky people who spontaneously clear the infection, that usually happens in the first 6 months of the infection. And so if an insurance is pushing back on this, they're going to want evidence that somebody's had this infection for longer than 6 months. So initially, sort of initial evaluation and counseling, once somebody is diagnosed with Hep C, most of the folks that I knew, that I evaluate have known that they've had Hep C for some time and have never really been evaluated or talked to about treatment. So I just talk about Hep C transmission risk, all the sort of things that we talked about, and the disease course of Hep C and why we care about it, and how it affects the liver. So I do a lot of counseling around that. And then just general counseling around healthy liver lifestyles, so alcohol abstinence or limited alcohol use. And something that we don't often talk about enough is the fact that obesity and overweight can really affect the liver. So fat also accumulates in the liver and can cause inflammation in the liver and scarring in the liver that can really contribute to increased liver fibrosis. So initial blood work, we have this really streamlined in our clinic and in our mobile clinic. So the day someone comes in, they get a rapid antibody test that's positive. We go ahead and try to draw all of their blood, including that RNA, that viral load that's going to show us for sure that they have a chronic infection, but we go ahead and try to draw everything else. So some of the important things are a hepatitis C genotype. So this just tells us you can see here, there's 1 through 6 different genotypes, and one has subcategories. This used to be more important because certain medications only treat certain genotypes. The medications that we tend to use most often now treat all of the genotypes. Insurance still wants to see that for approval. And then we evaluate the comprehensive chemistry, like a CMP and a CBC, that help us do some calculations around their liver fibrosis. I don't actually usually check a urinalysis, but it's on here. HIV test, obviously, hepatitis A, A and B serology. And this is kind of why I put the serology up there for Hep B in the prior section. I always check for immunity to Hep A, immunity to Hep B, and evidence of active infection or prior infection, and then immunize folks if they're not already immune to those. And then we need, importantly, we need one test to show kind of the level of fibrosis, which is called the Metaveer Score. Insurance in the state of Maryland will approve, will use either a blood test or something called a FibroScan or liver elastography. So the blood test is something called a FibroSure in our LabCorp system that we use. There's probably other versions of this in different lab systems, but they look at a series of biomarkers and they kind of spit out a result for you to show you a level of fibrosis that we'll look at on another slide. There are ways to kind of calculate this with just a CMP and CBC, but insurance requires one of these two tests to show their level of fibrosis. And so again, the level of fibrosis is called a Metaveer score. It's scored from F0 to F4. F4 being cirrhosis, F0 being we don't see any evidence of actual damage to the liver. And I think I have another screen on here, another slide coming up that has a picture of that. So we'll look at that in a second. The reason to do this is it's really important to identify if somebody has cirrhosis or we think they might have cirrhosis, because it does change the evaluation and kind of follow-up that's needed after treatment. And previously we had to show this because in Maryland, there was a requirement to have a level of F2 in order to get approved by treatment for treatment by Medicaid. They removed that in January 2020, which has been excellent. So really anybody F0 to F4 now you should be trying to get treatment approved for them. So this is liver elastography. It's a machine that kind of looks like an ultrasound, but what it does is it sends little kind of waves to the liver. It takes about 10-15 minutes. We have one in our clinic, and it kind of shows you a report that's measuring the stiffness of the liver. And the stiffer the liver is, the more scarring there is in the liver, and it kind of gives you this linear score. And so it can be affected by some things like body habitus, recent, if they've eaten recently, et cetera. But in general, it's like an excellent test, easy to do, non-invasive. And this is sort of a nice picture of the Metaveer scores. So this is a cross section of a liver. All the way on the left is this nice pink, smooth, healthy liver. And as it progresses through the stages, ends up being more scarred up when you get out to the F4, that is cirrhosis. I have a picture of this in my clinic, but it's a nice visual for patients. So if somebody has cirrhosis, there's a couple of additional things that they should be evaluated for. So the first is liver cancer. I mentioned to you that once you have cirrhosis, the rate of progression to liver cancer is about 1 to 4% a year. So the way to screen for that is just a liver ultrasound. It is different than the liver elastography. That elastography doesn't give you an image of the liver. So you can send a patient for a liver ultrasound, which again is easy and non-invasive. And if there's any evidence of masses, then you would refer them on to a specialist for further evaluation. And anyone with cirrhosis should also be getting screened for, should be getting a burnendoscopy to look for esophageal varices. Again, not something that we're usually doing or referring people for successfully in our clinics, but is part of the cirrhosis kind of care. One point about the hepatocellular carcinoma, one reason it's kind of important to identify that before you treat somebody. You're still going to want to treat their Hep C, but if somebody has hepatocellular carcinoma, there is a chance that they might qualify for a liver transplant. And that evaluation kind of should be done because there's a lot of transplant activity happening now with Hep C positive organs and doing the treatment kind of post-transplant if somebody's able to accept a Hep C positive organ. And that's true for like kidney transplant things too. So the next thing to think about when evaluating somebody's drug interactions, there's there's certain categories of meds that tend to have a lot of interactions. And unfortunately, some of them are meds that people are frequently on. So meds for stomach acid, PPIs, statins for cholesterol, seizure medicines, and then some HIV medicines. But this website is excellent. So the University of Liverpool has a website for hepatitis C drug interactions. They also have one for HIV drug interactions, and they actually have one for COVID therapies as well. It's really user-friendly. If you just Google like Hep C drug interaction, it'll be the first thing that comes up. You can put in your Hep C drug, you can put in any of the other drugs that they're on, and it gives you really clear like green, orange, red. You can look at adjustments to medicine, look for alternatives, etc. It's really excellent tool. So the medicines, in the past, many years ago, people were treated with interferon, which was, an injection drug, an injectable drug. People had to take it for a long time. They had a lot of side effects and very low rates of cure. And for the past, I don't know, decade or so, coming up on a decade, we've had direct acting antivirals, so DAAs. There are many options available now, and they're excellent. More than 95% of people are cured if they take them appropriately. Very few side effects. People have a little bit of fatigue, headache, maybe some stomach upset, but that's actually rare and usually goes away in the first week or so. And then the course of medication is 8 or 12 weeks for most people, depending on the medicine that you're using. And really the most important thing is just daily adherence to the medicine. It is a little bit forgiving. People can miss a couple of, a few doses. But we know that when people take the full course of medicine, again, they're going to be more than 95% of people are cured. So this again is that HCB guidelines website that I'm just kind of screenshotting for you. There are these kind of simplified treatment recommendations here. And there's one for people without cirrhosis and one for people with cirrhosis. And I don't have everything on here, but this is literally one page that shows you everything you need to know pretty much to go through treatment with somebody. And I won't talk about all the details here. We've talked about a lot of this already, but the main two medications that we use now are Metaveer and Epclusa, and their generic names are there for you as well. Metaveer being 8 weeks long for most people, and is the preferred medication for the Medicaid MCOs. And then Epclusa, which would be 12 weeks long. Both of them treat all genotypes 1 through 6. And then this is a similar page for folks with cirrhosis. And again, it just points out that people need more evaluation for their cirrhosis before starting treatment. This information, hcbguidelines.org. So monitoring on treatment really is about just ensuring that people are taking their medication appropriately and ensuring adherence, and that people have a schedule. When we start somebody on treatment, we actually print out a schedule for them, like this is the day you're starting, this is going to be when you get your refill and your follow-up lab work. The Metaveer actually comes in a big box, which is kind of annoying that it's a big box, but what it is like there's one box, inside of that box there's 4 boxes, and each of those 4 boxes is 1 week of medicine, where you pull out each day has a little pack. It has 3 pills that they take all together with food once a day. But it really helps, and then they can punch out, just like with a pill box, like punch out, like I took Mondays, I took Tuesdays, like whatever, to keep them on track. So it's, in that sense, is really packaged nicely for adherence. For treatment monitoring, we used to always have to get labs after 4 weeks of therapy, and insurance was usually requiring that. With the shorter courses, with the 8 weeks of Metaveer, you don't really need that monitoring for people who don't have cirrhosis. I still get it on a lot of people because sometimes insurances are requiring information you don't want to be lacking in it, but clinically in the guidelines, you don't need that for people who are not cirrhotic. And then if somebody is on a course of medicine that's 12 weeks or longer, if they had reasons to have a longer course, you do want to get it the 4-week labs, because insurance is going to want to see that in order to refill their medication. And then we check labs at the end of treatment. And what we're checking is the viral load and a CMP to kind of look at any evidence of liver inflammation. After somebody's cured, so after somebody completes those 8 weeks of treatment, 12 weeks later is when you're going to draw labs for the last time. You're going to look at that viral load again. And that's when that's undetectable, that's when we can tell somebody for sure they're cured. In my program, this is the people kind of fall off here. It's sometimes we have trouble getting people back in to see us to get that last lab and prove that they're cured. It's very, very rare that somebody has taken their course of medicine, their labs look good at 8 weeks, and then 12 weeks later, they come back and their viral load is positive. That it can happen if the for that small percent of people who are not totally cured. So that's the reason to get that lab. It's also nice to have it because then if they have a positive viral load sometime in the future, you'll know whether it was a treatment failure versus a reinfection. So the next point here is that reinfection is possible. So this is something really important to counsel people back about. So even if you're cured, if you're at risk, if you have those risk behaviors or exposures in the future, you can get reinfected. It is treatable and curable again. And I've gotten insurance to approve treatment of reinfections. And then, as I mentioned before, that Hep C antibody test is always going to be positive. This is something that's kind of confusing to patients because they may go to screening fairs or their primary care, somebody's going to do a Hep C antibody test and it comes back positive, and they're like, well, I thought it was cured, it's positive. So I try to really kind of go through that and explain to them that if that comes back positive, if they're worried about reinfection, they need to check that virus level again. Anybody who has cirrhosis should be followed by a provider who's going to monitor them periodically. So currently the recommendation is a liver ultrasound to screen for cancer every 6 months, kind of indefinitely, because the risk doesn't go away even after you cure the Hep C. The liver can't undo all of that scarring, even if the inflammation goes down. And then just continued counseling about a healthy liver lifestyle. So take-home points. Hep C is really common and really has a lot of morbidity and mortality in our country and in our state, and particularly in Baltimore. Screen with the guidelines, which really are simplified now because we don't have to do as much risk assessment. Really, everybody should be tested at least once. Retest for people who have ongoing risk. Treat regardless of stage of liver fibrosis, regardless of ongoing risk behaviors. Really easy to take medicine that cures almost everybody, and people can be reinfected. Here's a couple of the references for you that I mentioned, and here's my email address if anyone has ongoing questions, but happy to answer any questions now.
Does anyone have a question here? I do have a comment first, and if you don't mind repeating it so people online here. Someone was wondering if it will become recommended that children get a booster of hepatitis B around age 12 or so. When screening people, we find a lot of young adults in their early 20s show to be not immune.
Right, so the comment was that there's, with serologies now for young adults, that hepatitis B immunity is waning, even though they've gotten the vaccine as younger children and babies, and whether there's going to be a recommendation to get a booster series for that. I'm not aware of that, but I think that's a really important point, and that these guidelines, the important point is that guidelines change based on as things roll out. And the epi that we have, I think, like I mentioned, it is common to have your immunity wane to Hep B vaccine in general, but I'm not aware of a recommendation to retest or revaccinate people with boosters, but that may come.
Okay, and then one other question: does transient elastography evaluate for fatty liver or NAFLD?
So, right, so the question is, does the transient elastography evaluate for non-alcoholic fatty liver disease? And yes, it does. It can give you a score regardless of the reason that you're sort of having damage to your liver. In my clinic, because of where I work at the health department and we're only treating Hep C, we're not kind of a liver specialty clinic. We're only using it for the Hep C evaluation, but it does give you a fibrosis score regardless of the etiology. Yeah.
Go to the back.
I just wanted to know what the recommended age range.
That's a great question. And sorry, the question was if a newborn is exposed to Hep C, when do they get tested? And to be honest, I would have to look at exactly the series of testing that they need for how long of follow-up, because I know they should be tested right away, but there is, I think it's like 6 months to a year that they need to be kind of tested and followed up to see if they have their own antibodies. That is in the guidelines, I believe, and I'm happy to look that up and kind of send it out to the group if you're interested.
barriers individuals experience who didn't have a fiber scan at 4 or later prior to 2020 or getting more medicated? Did you see like an influx of some of these patients back to the same treatment once the legislation changed?
Yeah, I think that's a great question. One thing that was complicated about that is that changed on January 1, 2020, and then COVID hit in March of 2020. So a lot of programs, including my own, like changed sort of how the influx of patients that we were having for these services. And so I don't know if I can give you a clear answer to that, except to say that I certainly treat a lot of people now who have F0, F1, who wouldn't have qualified before. You know, the really frustrating thing about when there were those restrictions is that people would come in and we would say, like, we can't get this approved, or we'll try to get it approved, it'll get denied. We could try to go through patient assistance programs, but you know, people kind of drop off before getting through that process. They get frustrated. They're like, they don't understand, you know, what that meant. And then, you know, young women might get pregnant and have a baby, and they weren't able to be treated. And we had that very case happen at the health department. And so that was really frustrating. And now it's really nice to be able to get treatment approved for everybody. And even, you know, I mentioned also the, you know, drug use and alcohol use not being a reason to deny treatment. That used to be kind of a barrier that Maryland Medicaid put up, and a lot of other states still do. Through some advocacy work, they've kind of tried to remove that, and I have not had people being denied for that reason. A lot of the work that I do is in a mobile clinic. We're out kind of on the street. People who are injecting actively come to us, and we're able to get medication approved for them. So it's been a nice change over the past couple of years.
Or like anytime soon where there will be virtual hepatitis testing in PRs, so like there's HIV, or there's one for legalization for patients and how that would for, you know, insurance coverage or things like that in the same way.
Yeah, so the question is around kind of a change for universal Hep C testing in the way that there is for HIV. I will say in Baltimore, even for the last several years, I think some of the major EDs in our city have been doing Hep C testing, even with rapid testing. And I don't know that there's accurate data on how often people are routinely screening in primary care clinics and other kind of settings. I think a lot of this is kind of education of all providers in the system to know about these screening guidelines, that everybody should be tested, and probably like having workflows in people's, you know, EMRs for like all the sort of health maintenance pop-ups that people should be doing. It's just like, you know, in a primary care setting, people should be getting their mammogram, their colonoscopy, their cholesterol check, their HIV test, their Hep C test. It should be sort of a standard of care that everybody's doing. And I hope we get there, but I don't know that we have good data yet on how often people are really testing in those settings.
Dr. Richmond, I looked up on hcvguidelines.org, and the recommendation for children born to HCV infected mothers is retesting at using antibody-based tests at or after 18 months.
18 months, okay. So just to repeat that, testing for a newborn exposed to, for a mother that was Hep C positive, is antibody testing after 18 months.
And someone else made a comment, they may have missed this in your talk, but have you seen conversions of hepatitis C from a needle stick in the setting of a healthcare worker?
That absolutely can happen.
Can you repeat?
Yeah, the question is whether people can get Hep C from a needle stick, like healthcare workers. Absolutely, it's not something that I see often just because of the population that I work with in the setting that I work, but certainly if you're working in a healthcare setting and you have a needle stick, it's one of the three things that they want to make sure they test you for is HIV, Hep C, and Hep B. I actually had a needle stick in my clinic from someone who had been recently cured of Hep C, and I work with my occupational health for testing and then retesting 6 months later.